Hello everybody and welcome to this talk about POCUS guided fluid resuscitation. I'm Johnny Wilkinson and I'm very privileged to be here and be invited by Zaf to talk to you guys all about this subject. Now, obviously I do a lot of adult stuff, but I think much of this, if not all of it, in fact, is very applicable to the paediatric population. And obviously point of care ultrasound is a very popular side to critical care, certainly, and it's something we can all learn to benefit our patients. So I'm going to talk to you how it can benefit us for fluid resuscitation, which is a hugely important subject. So this is me. I'm a consultant intensivist at Northampton General Hospital, and I'm also a complete ultrasound lunatic. I run a group called the Ultrascoundrels, and you may have seen us on Twitter, a group of us from all around the world, and we talk about all sorts of things to do with ultrasound, do lots of teaching, etc. I'm also the founder and CEO of criticalcarenorthampton.com. I sit on the FUSIC committee at the Intensive Care Society, and I also run various courses around the country and sit on various faculties, which I won't bore you with at the moment. If you want to follow me on Twitter, please scan the QR code here. So on to the nitty-gritty. So IV fluids. Now, one thing I will say is that the only true and sensible fluid is physiological fluid, and that's oral fluid. So unless there's a reason why you shouldn't have oral fluid or can't have it, then that should always be the modality of choice to deliver fluid. However, all of this spanned from 1832 cholera epidemic, where some bright spark decided to pop needles in, connect some tubes to them and infiltrate the veins with IV fluid. And some of it was just water, in fairness, with some salt in. And the discovery was that it may have been helping these patients to avoid death, which was by acidosis and dehydration. So we shouldn't really be practicing the same stuff that they did in the cholera epidemic, because there was a basic principle involved there. Step one in this recipe is always to take a good history, and I know it's telling you to suck eggs, as it were, but it's so important because patients are not hypovolemic as we think they are in a hospital. I think this is over-treated and over-assumed. True hypovolemia comes in the history. Has there been extensive and persistent vomiting? If so, yes, the patient may have lost salt and may have lost a considerable amount of water, therefore are hypovolemic. Dehydration goes without saying. If patients have a big history of this, then yes, they may be hypovolemic as a result. Copious amounts of diarrhea, such as the cholera epidemic. We don't see that much these days at all. However, diarrhea and vomiting in combination leads to dehydration, which leads to hypovolemia, salt and water loss. And of course, blood loss, particularly in trauma and in children. The amount of volume lost or allowable blood loss is certainly worth considering, because this is definitely a true hypovolemic state when there's been a significant amount lost. So the history is really important. The next thing that's really important is that we are safe and that we consider physiology at all costs when we're infiltrating our patients with IV fluids, because they are drugs. No one wants to see our patients like this. This is an unacceptable state to be in. So no patient should leave hospital completely dehydrated and or hypovolemic. And in fact, this is a rare situation, because in fact this is the more common one, and this is edema, and this should not be seen in patients. The only reason there is edema in this patient here is because they are truly volume overloaded. To have edema like this due to no other cause, the likelihood is that patients are volume overloaded. Patients gaining weight in hospital, unless there is an oncotic reason for it or any other reason for it, is usually due to fluid overload. And this happens to so many patients around the country and around the world. We've got to remember that fluids are drugs. Really important. They are not benign compounds. A whole litre of fluid, such as normal saline, which I can't stand, is a drug. So all fluids need to be considered such. They have a dose, they have a duration, and they also have a de-escalation, and this part is really important. So the 4 Ds of fluid therapy must be considered at all costs. Now then, what is normovalemia, or euvolemia if you like? Let's give you a model. If we examine the human body, and think of it as a tank. This is crude, I know, but if you think of the paediatric population, they're just walking tanks, 60% water by volume. In adults, certainly about 42 litres worth of water in the average human, worth 70 kilos. So in children, we've got a different balance, I know, but there is a significant amount in the tank. Now then, where is most of that accessible volume? Now it sits within the splanchnic venous circulation, so that's in the gut. Huge capacitance within this system, and we can utilise that in order to help our patients. So here is a splanchnic circulation. It's a venous circulation. It has a low resistance, and in order for there to be flow from it to provide venous return, there must be a high pressure to a low pressure system. So in order for flow to go from this, we need to create some form of pressure within it. Now then, there are two sides to this. The stressed volume at the top. This one plays an important part, whereas the unstressed volume doesn't. So if we consider the unstressed volume to be the resting state of the venous circulation, i.e. exerting no particular pressure, then that isn't going to cause any flow. However, the stressed component is, and this is what we can influence with sensible volume replacement and or sensible administration of IV fluid. So that stressed volume provides a pressure which provides a flow which provides venous return and a subsequent cardiac output at the other side. So the right side of the circulation basically equals the left side of the circulation in cases of stability and where the situation remains normal. So what can we do to influence things? And what can we do to influence that stressed volume which provides us with more venous return? Well, we can certainly expand it, and of course we can do that by providing IV fluid. Now I know this is 5% dextrose, which is a bit of a devilish compound because it's basically free water once metabolised, but I'm just giving it as an example. So sensible administration of IV fluid will cause an increase in stress volume, which of course will cause, hopefully, this is the aim of fluid, an increased venous return, which results in a cardiac output increase, which is what we're all looking for when we prescribe fluid sensibly, because this is probably the only reason we want to give it. What about vasodilatation, sepsis, systemic inflammatory response syndrome? Well, the situation changes quite dynamically here, and this is what people get vastly wrong. People think that septic patients require vast amounts of fluid, and the Surviving Sepsis campaign told us to give resuscitation doses that we all think were probably too much, 30 mils per kilo. We think more like 20 to 25 would be more sensible, because too much IV fluid in sepsis, certainly early on, can cause real problems, and I'll explain why. Here's the tank now, and you can see that we've got basically a spread. The tank is expanded, and this is what a vasodilatation state does. We get tank expansion, and we get those leaky venous circulation and leaky capillaries. Therefore, what we put in is not going to remain where we think it is. In fact, it causes a lot of trouble. What we're trying to do is to optimise our mean systemic pressure, and indeed the mean systemic pressure pretty much is the balance between the stressed volume providing flow and the unstressed volume which doesn't. So the greater the stress volume, the higher the mean systemic pressure, the greater the flow. So here's our unstressed volume now, and here's our stressed volume, and you can see in a vasodilatation state, the unstressed volume, i.e. the one that doesn't provide flow, is a greater component of the overall mean systemic pressure. So in this circumstance, there's the splanchnic circulation, there's the venous capacitance system, and you can see most of it is unstressed now because that tank is expanded due to vasodilatation. Therefore, there is a much lower flow, there's a lower venous return, and also a lower cardiac output, which is why we see hypotension and tachycardic states in sepsis. So sensibility comes in here. Of course it should. However, we get it wrong, because what we do is we provide IV fluid. Then we give more, and we give some more. And by that point, we've overdone it a lot of the time, because what happens is it leaks out, it sits in the vital organs, and we get multi-organ failure due to volume overload, and we get a cascade of demolition of most of our internal organ structures if we carry this practice on without thinking sensibly. So you can see here that giving too much fluid in sepsis, early on particularly, and continuing that amount is extremely detrimental to the survival of our patients. Particularly important in the paediatric population, where even tiny volumes can make that huge difference. We've got much more breathing space in adults, so I do really feel for you guys in paediatrics. Now then, sympathetic surge. This is what's important and this is what helps us. So here's the tank again in a vasodilated state. In sepsis, of course, we get surges of adrenaline and surges of noradrenaline to try and increase cardiac output via venous return increases, venoconstriction and vasoconstriction. So you can see here again, the unstressed component provides a little bit more than the stressed volume does in an attempt to get flow out. Therefore, we don't have much. However, we do have something, as I've mentioned, called noradrenaline, and we can use this as a vasopressor, and you all know about this on ICU, and sometimes this is the best option when we've tried to resuscitate patients and had little response. The best thing to do is stop, think, and refer, and maybe get some vasopressors on board with higher level monitoring, which is where ICU comes in. So here is the alpha receptor. We're full of those, and they're all over that splanchnic circulation. And when stimulated by noradrenaline, of course, we get vasoconstriction. As I said, we've got plenty of alpha receptors in the body, and they are particularly rampant in the venous circulation, causing significant venoconstriction when stimulated by noradrenaline. So what we're effectively doing is decreasing the size of that tank back, getting rid of wasted volume, and we are pushing the unstressed volume back into the stressed volume, which subsequently increases the potential for flow, increasing venous return and cardiac output. Much more sensible option rather than the previous slide shown, flooding the patients. Great example here from Ashley Miller. He's showing what vasoconstriction does with noradrenaline, say, and we are squeezing the unstressed volume up into the stressed volume and increasing our venous return on the side. Really good model. Now then, this is where point of care ultrasound comes in. You must have been thinking, he's been banging on and we haven't even got to it yet. So here we go. How can point of care ultrasound help us? I want you to look at this graph here. There is a rose in the background. The reason there's a rose in the background is for a very poignant reason. Consider the graph, volume status against time, and the ROSE principle. Now, ROSE is an acronym for resuscitation. This is the first hit. This is the part we want to influence to combat shock. And this is the really important part, expansion of circulating volume sensibly and acutely to prevent morbidity and mortality. Then we go to O, organ support, the second hit. And this is where we need to start to get maintenance considerations on board and keep the patient stable. Beyond that, we get stabilisation and then, importantly, evacuation. Now, I can't emphasise enough, evacuation is something that is forgotten too often and done very badly. So if we look at the total volume of fluid put in over time, you get a curve like this. Obviously, acutely, we get resuscitation, then we support the organs, and then we try to stabilise and then evacuate later on. And this is where POCUS comes in really handy, and I'll tell you why. Let's look at those components, starting with resuscitation, the first hit. Here's a parasternal long axis view. Left sternal edge, marker to the right shoulder, and we get an image such as this. Now, if you're all echo competent, I do apologise for telling you to suck eggs here, but this is the long axis view, and I'll just point some things out. This is the right ventricle, the left ventricular cavity here, the mitral valve here, anterior leaflet, posterior leaflet, and the anterior leaflet gets somewhere near to the septum when there's a decent cardiac output. Left atrium here, aortic valve and outflow tract there. So this is the left side we're looking at here, and there's the descending thoracic aorta down the bottom. So you can see here there is a decent heart rate, it's not hyper fast, and it isn't too slow. The left ventricular walls and septal walls are thickening nicely on each systolic contraction. This is a steady state of normality, but in someone who might be really hypovolemic, you can see a very rapid heart rate, a left ventricular cavity that's almost closing off entirely, and that mitral valve leaflet there is slapping right up to that septum to the point it's nearly obliterating the cavity as well. So this is a hypovolemic state. You could assume all other things remaining equal if you get this view, so that's a very useful thing to look at first. rotate the probe through 90 degrees to get the short axis view, and here we see the dancing donut that we all described. That's the left ventricular cavity, that's the right ventricular cavity. Notice the septum goes outwards in a convex fashion into the right side. That's because the pressure in the left exceeds that in the right. So obviously if you get volume overload here, it'll push the septum this way. These are the papillary muscles, and when they headbutt each other and literally close the cavity off, that could be assumed to be hypovolemia. But again, nice thickening, lovely steady heart rate, papillary muscles that are not headbutting each other, and a decent cavity on diastole visible. However, hypovolemia, you can see we're banging away here at some rate. You can hardly see the RV at all because there's hardly any venous return in there, and this is not a happy short axis view. If you run an M-mode cursor across, and you can see the M-mode cursor just down there, run that and you get this view here. And I want you to just demonstrate here that we've got hardly any volume in diastole remaining because it's slapping itself pretty much shut. And here is the papillary muscle equivalent. There's hardly any gap at all between the septum, there's hardly any gap remaining because the LV cavity is pretty much shutting itself off. So this is demonstrated by M mode, that we've got a very rapid heart rate and an LV cavity that's pretty much closing off. Apical 4-chamber view, very useful view to look at. You should really have more or less a 1-to-1 ratio between right and left ventricles, right atrium and left atrium there, sorry. And you'll note there, again, steady heart rate, nice contraction of the left side, and pretty happy right side as well. There's the tricuspid valve, there's the mitral valve moving away, a happy heart. Again, here is a very hypodynamic 4-chamber view of someone with hypovolemia, and you can see the cavity almost obliterating itself there, hardly anything in the right side at all. So you can see a vast difference between the two in hypovolemia and normovolemia. The subcostal view, very nice view to look at and quite easy most of the time, particularly in some ventilated patients when you find the parasternal views very difficult. Nice steady heart rate, left and right sided cavities looking pretty normal, and similarly with the atria there, happy heart. Hypovolemic one, slightly more rapid, closing off the cavities more, and just generally empty. Now, here's the good old IVC. Everybody thinks this is the solution and the answer to whether a patient is hypovolemic, normovolemic, or whatever. I will tell you it isn't. In isolation, it's useless. What it does tell us is whether in extremes there is something to find. So, for example, if it's tiny, they might be dry as a crisp. If it's huge and not budging, they may be overloaded, but that's about all you can tell from it. So here it is, right atrium, IVC there, and there's a hepatic vein just coming in. And we usually measure it just at this point after the hepatic vein, and you'd gauge that with the machine, and roughly it should be around 2 centimeters in adults. In children may be a slight difference, but the measurement and extremes are important as an isolated thing. If we look at this example here, I want to explain about the dynamics of the IVC and what we're concerned with. So, if you get a patient who's spontaneously breathing, that's a negative pressure breath in. So if we sniff, for example, you will see changes. Sniff in, take a deep breath in, get a drop in intrapleural pressure, a drop in right atrial pressure, and because the IVC empties into that right atrium and the pressure's dropped in it, you get flow from the IVC into it, which increases venous return. Therefore, you see a decrease in the size of the vessel as it empties out. If you look at the long axis view, inhalation, exhalation can be seen there. It collapses when we breathe in or sniff, and it expands when we breathe out for the reasons above. That's called collapsibility index in a spontaneously breathing patient. And we usually say collapsibility index of 12% or 20% or more may mean the patient should be volume tolerant. Everyone's fluid tolerant, we're talking volume tolerant here. So if it collapses loads, they might be volume tolerant, they might be hypovolemic, but consider the other things we've looked at above with the other views. Don't look at it in isolation. So then, what happens when we put patients on ventilators? It changes, because a ventilator provides positive pressure, which changes the dynamics of what the IVC does. People get this wrong. Now, the IVC and its measurements and collapsibility, or distensibility when we are on ventilator, is more highly validated as an assessment measure for volemic status. So, increase in intrapleural pressure, positive pressure breath. You get an increase in right atrial pressure because the increase in pressure in the right atrium precludes the IVC not emptying into it as well anymore because the pressure gradient for flow has dropped down. We'll see an increase in size of it with a positive pressure breath in. So you get the opposite relationship going on, and that's called a distensibility index. So I think everyone should understand that these situations are reversed with the IVC. So here's a good example. Here's an IVC that's pretty much collapsing to shutting point. We didn't give any fluid. We give a litre of IV fluid with obviously careful fluid challenges, and you can see it's expanded. So this may be a positive responder. And in this one, this is 2 litres of fluid, and I would say in adults that's the upper limit of what you should be giving anyway before you need noradrenaline and stuff and ICU advice. This is expanded. You can see it's still bobbing closed here at the junction with the right atrium. So there's probably a little bit more room there, but you've probably done a good job considering the first image. So that's the first section. That's resuscitation and first hit and what you can see. So what about the optimization side of things? So there's something called left ventricular outflow tract measurement. So if we look here, here's the LVOT, and I'm going to talk about VTI, which is volume time integral. And this is something we can measure, and we can gauge how it changes over time with fluid challenges or passive leg raising to gauge whether a patient can take more volume or not. LVOT, get your long axis view, and you measure it in mid-systole from where the aortic valve leaflets begin, and it should be roughly 2 centimetres in adults, okay? Maybe slightly smaller in children, obviously, but you measure it here via the formula pi r squared from the diameter and radius. You can work out roughly what the volume is, and it will give you this via pi r squared. Then what happens is if you put pulse wave Doppler through your 5-chamber view of the heart, I'm going to show you this in a second, you can then get the volume time integral, and you can work it out. Essentially, the greater the volume time interval, i.e. the greater the amount of blood that's chucked out through there via the volume you've calculated, you can gauge cardiac output is greater. The higher the VTI, the greater the cardiac output is. And obviously, cardiac output is stroke volume times heart rate, and you've worked the volume out via these formulae here with the VTI, times it by the heart rate, there's your cardiac output. Clever measurement, and some machines have auto VTI functions and artificial intelligence that will do it for you. In some other machines you've got to measure the LVOT diameter and then plumb in the figures once you've done the pulse wave Doppler to get the VTI. The passive leg raise is a fantastic tool to assess a patient's volemic status and the potential to be volume tolerant. We don't use it often enough, but a patient who's got a high pulse rate and a low blood pressure may be hypovolemic, so we don't need to plough IV fluid in. Instead, we can utilise the 500 mils or so blood volume in the legs to give them some increased preload when we tilt the trolley to 45 degrees or lift the legs. This sends the blood flow more centrally, increasing preload and hopefully increasing cardiac output. It's a 500 ml auto transfusion that will hopefully cause a decrease in pulse rate and an increase in blood pressure, therefore showing a fluid response and volume tolerance. Tilt the trolley back, of course, that blood volume will disappear back into the legs, and if they're a transient responder, you may notice the pulse rate rises again and the blood pressure falls, meaning IV fluids may be potentially of benefit. So we can now demonstrate the effect of this passive leg raise and the auto-transfusion of blood by looking at detailed cardiac output monitoring using the Venue-Go system, the AI inbuilt auto-VTI function, apical 5-chamber view on me, pre-passive leg raise, stroke volume of 64, and an LVOT VTI of 20.3. Passive leg raise and give me my auto-transfusion of blood. We repeat the same VTI measurement, and then you will see that after the passive leg raise, my stroke volume's gone up to 76 and the VTI 24.3. This has demonstrated volume tolerance. Drop my legs back down, we're back to 52 and 16.7 on the VTI. Now, if we press another button on our trusty machine, the VTI trending button, it will demonstrate exactly what you've just seen on the previous measurements. Pre, during PLR, and after. On this curve here on another subject, we demonstrate 19.4, 22.4, and 20.1. This demonstrates a positive response to the passive leg raise and a volume tolerant patient. So that's LVOT VTI and how that can help us to gauge how a patient may accept volume. So obviously if you get an increase in the VTI measurement after you've done a passive leg raise and given them the auto transfusion, they are going to be volume tolerant when you give a fluid challenge. So then repeat the measurement after the fluid challenge and you should notice the VTI is increased. So that's a pretty good way of gauging fluid response and volume tolerance. The next phase is the most important part, and this is where ICU come in handy, and this is where ICU more and more having to swoop in and help patients because they have been volume overloaded with overzealous amounts of IV fluid, the evacuation phase, the last part of ROSE. So if you look at this view here, we can see an LV cavity that is full. It isn't closing off much. The rate has slowed down. That mitral valve ain't moving much. And the right side's pretty hefty. We can't even see the wall here. It's over here. This could be a volume overloaded patient. Similarly, lung ultrasound comes in. So heart-lung interaction's dead important. Look at the lungs. They can tell you whether you've overloaded those tanks. Here's a normal view. Here is a rib shadow and another rib shadow, and this is what lung ultrasound looks like. Sliding pleura at the top here, going backwards and forwards, and the reflection of that pleura comes down here, and these are called A lines. They're horizontal lines. This is a normal view. Whereas the view here, you can see there's the pleura sliding backwards and forwards between the ribs here, and from it you can see lines coming all the way down from top to bottom, right to the bottom of the screen from the pleura. These are B lines. B lines can only be transmitted sonographically if there is fluid interface interfering with that air that we've seen going straight through here. It's a totally different picture, and this is extravascular lung water from fluid overload. So we can notice volume overloaded patient with that previous echo image. Lungs look like this. This is probably extravascular lung water and volume overload, so we can actually diurese a patient to see removal of these B-line profiles. There's your B-lines coming right down from the top to the bottom of the screen. Now then, here's another example. VEXUS. This is venous excess ultrasound. It has become the thing at the moment, and this is looking for right-sided pressure overload due to too much volume. Now, there are other causes of right-sided pressure overload, we know that, but in someone who's previously fit and well, who's come in and been volume overloaded, venous excess ultrasound can be helpful in order to offload them. And what it is that the right side of the heart communicates with the vital organs as they return their venous flow. When the right side gets overloaded and stressed up, you get back pressure, and that back pressure can be found and reflected in some of the big vital organs such as the liver and the kidneys, for example. And we'll show you what happens when things change. So again, we've got an IVC, top left here, which is closing shut, not much of a problem. This one here is expanded and plethoric. It is wide and it is not moving very much, as you can see. So if you've got this image up here, the patient's pretty much not volume overloaded. They can't be with an IVC closing like that. However, the bottom image, they definitely can be because it's huge and not moving much. So if you see an IVC, and funnily enough, IVC measurement step 1 of VEXUS, if you see it overloaded, you can then pass on to the next part. I'm going to show you what the components of VEXUS are. If you look here, we are scanning for the hepatic veins. There's loads of them in the liver, and if you put the probe in a sort of subcostal position, marker up to the patient's chin, and move it around, find the right atrial junction, you'll be able to see the hepatic veins, and you can see them coming in here and down here, and there's some more of them here, and you will also be able to see them branching off through the liver. They are very dark and they don't have echo bright walls. Now, once you've found them, you can then fire pulse wave Doppler and colour across them as demonstrated here. Colour flow gets activated, and you can see there we've done that, and we press the pulse wave Doppler button, fire it, and you will get your hepatic venous waveform. This is a normal one. Now, what I like to point out here is that if you look at this flow, there's quite a lot of action below the baseline and less on the top, and I'll explain why that's important in a moment. That's a normal hepatic venous waveform. So the next thing we're going to talk about is what it looks like in normality and what it looks like when it's abnormal. And here we are drawing the hepatic veins for you. Let's remove those and show the crude anatomy there. Portal vessels are echo bright and the hepatic veins are dark like tree trunks. And here is that normal hepatic venous waveform. The components can be labelled up. A is the atrial systolic component, upward deflection above the baseline. Ventricular systole and ventricular diastole are downward deflections below the baseline in normality, as A and S and D waves. Now, when the situation becomes abnormal, you can see huge dilated vessels here. Fire the pulse wave Doppler over, and we'll talk about the different flow patterns as right atrial pressure increases and backflow increases. Green on the top, normal one, with the A, the S and the D components. Now what I want to point out here is that the systolic component starts to drop off and go above the baseline, and it does that as progressive venous pressure goes up. So we can see here through the patterns you're getting a drop off of the systolic waveform gradually and slowly until it's above the baseline. So we call this reversal of flow pattern. So hepatic venous waveform reversal is abnormal, and that means they're congested. Next thing we want to do is look at the hepatic portal vein. This is a big structure that can be found most easily going from around the side below the ribs, and we'll just fire the image off here and you can see this is the porta hepatis. It's large, and look at those echo bright walls. They're very white, which discerns them from the veins you can just see coming in down here. Very echo bright. Fire the colour in and you get a spiralling waveform of blood flow. It almost looks like a huge artery, but it is spiralling, which gives it that funny colour pattern. Again, once we fire a pulse wave Doppler across, we'll get the waveform, and it's a lovely phasic, slim looking waveform. Now, I just want to point out here, this one has got an oscillation to it because this subject is fit and well, and in athletic hearts, some of us get pulsatile hepatic portal venous waveforms, and that is not abnormal, it's just a fit and healthy subject. So again, let's talk about this and show what's normal. Fire the pulse wave Doppler over, and here is our normal hepatic portal flow pattern. It's phasic and most of it's above the baseline. So let's just label it up for you and show you what it looks like. And here we are. Lovely, phasic, and pretty much quite boring actually. However, let's talk about what goes wrong, and you can see again a lot of congestion here, and once we fire the waveforms through as right atrial pressure increases, we start to develop pulsatility of this waveform, as demonstrated here, and when it's really severe it actually dips below the baseline. So pulsatility developing and then dipping below the baseline in severe congestion. The next and final part, if you're brave enough to do it, is to scan for the peripheral vessels in the kidney. Now I find this very difficult in ventilated patients and people breathing very rapidly because it's tough to do because they're so small. But here's a lovely view of the kidney, as you can see here. And then what we can do is label it up with lots of colour, and you will see sort of flames coming out in the outer third of the cortex as I show you the next image. So there we go. Kidney lovely and lit up, as you can see, and you can see venous and arterial waveforms. What you want to do is actually catch both together. This waveform here demonstrates that. You've got systole, diastole, systole, diastole, systole and diastole. Here is the venous waveform below the curve. So you've got a combination. What happens as congestion increases is the diastolic component drops down, and you'll get an increased difference between the two, and that is a resistive index if you take one from the other. So the higher the index, the worse the congestion. And here is the measurement. Systolic peak, take it down to the diastolic dip, and you will get your RI, and it's 0.5 here, as you can see on the machine just there. Anything above 0.7 is abnormal. Just to summarise all of this together, let's look at the normal waveforms. Again, pulsatile, hepatic venous waveform there. That's all lovely and normal. And then we've got the portal venous waveform down here, lovely and phasic and above the baseline. And then the kidney waveform, intrarenal venous Doppler, systolic, diastolic, systolic, diastolic, and a little bit of venous stuff below. As we get more congested and right atrial pressure increases, we start to see systolic drop-off, and things are getting more action above the line. And as we get even more severe, you can see this pattern developing. Systolic waveform above and diastolic is still below, so that goes above the curve and we become reversed in our pulsatility. As we progress here, we get more and more pulsatility of the portal venous waveform, and again, as I mentioned, a diastolic drop-off in this kidney waveform here, and you can see far more action and pulsatility below the baseline when it gets really severe. So those are the differences as we progress with more congestion. Here's an example. Dilated IVC. Okay, stage 1. We can go to the next bit. Look, dilated LV and RV. And you can see that in the short axis view as well, septum bowing the wrong way, and a dilated 4-chamber view. Dilated hepatic vessels, blatant, portal vein pulsatility, there you go, and hepatic venous systolic reversal. So this is someone who's very congested, and that's a live clinical example for you. We're getting there now. So I just want to talk about VEXA score and then we're done. So the VEXA score, venous excess score, is broken down into 0. VEXA 0 means you've got an IVC less than 2 centimetres. Therefore, don't bother going any further. If you've got an IVC less than 2, you cannot be volume overloaded. You don't need decongesting. A VEXA score of 1. The IVC is above 2. Move to the next one, so start looking at your other waveforms. You can have normal patterns, but an IVC above 2, that still gives you a score of 1, but you might have some mild abnormalities. That's a 1. By the time we get to 2, we've got a severe abnormality in at least one pattern with your IVC above 2. And in the worst case, number 3, IVC's above 2, and you've got severe abnormalities in nearly all of the patterns there. VEXA 3 needs some serious offloading, might need the filter to remove fluid, might need severe diuresis. But that patient's volume overloaded, needs decongestion. So that's what VEXA is about, and it's quite advanced and it's quite new, but it's really quite easy to do once you get the hang of it. Before we finish, a little bit of myth busting about IV fluids in sepsis. Less than 50% of us will respond to a bolus, full stop. It's unproven whether boluses actually improve organ perfusion at all. Boluses are temporary, so don't give one, walk away and forget about it, because they don't last. 85% of most fluid boluses are gone in healthy individuals in 4 hours, and in 90 minutes in sepsis. Fluid overload is bad. It causes worsening multi-organ failure, certainly with acute kidney injury, and worsening breathing situations. So ARDS, acute lung injury, and in COVID, you must not overload those patients. It's vital you don't do that. Edema is terrible, and if they have got edema for no other cause, it's volume overload. That needs to be remedied. An acid-base disturbance. Clearly, if we're giving things like normal saline, which is not normal, we're giving copious salt loads to people and ending up with hyperchloremic acidosis. We should not have that. We should be using very sensible balanced crystalloids like Maintenolite or Plasmolite. And the theory is that we're moving harmful cytokines from a single organ sepsis focus all around the body. So what I'm trying to tell you is that fluid in sepsis is quite dangerous, and I think we need to be very careful. But using the tools I've talked about, we can be. So the 4 pillars of clinical examination are vital. Get a good history, and as I've said, think about your physiology. We need to inspect the patient, look at them. Are they swollen? Are they dry as a crisp? Think about the history. Palpation, yeah, tap around. Are they full of edema? Is it palpable? What's the skin turgor like, etc.? Percussion, yeah, might be stony dull at the bases. If you've overloaded them so much they've actually got pleural effusions. Auscultation, yeah, I'm less of a fan of the stethoscope these days because of handheld devices and the use of point-of-care ultrasound. I've hardly picked mine up at all these days. But if you're hearing lung creps, fine crackles and so forth, then you may have a volume overloaded patient with extravascular lung water. But finally, the 5th pillar of clinical examination should be ultrasound insonation. So we should all use this and we can all do it. So perhaps we should all learn. And that's me done. I hope you've enjoyed the talk. It will be hopefully available to you for you to keep. Later on, I will upload this to Twitter and on the website so you can keep it for later. Please scan the QR code on the left, go to critcarenorthampton.com and learn loads more about POCUS. And also I'd encourage people, particularly in the UK, to go and look at focused ultrasound intensive care, or FUSIC, and get themselves accredited. It's a fabulous system, and we've got some extremely clever and easy to follow modules, and you can get yourself accredited in whole body ultrasound. Thank you very much, and take care, all of you.